a depressive episode that's that bad, and you're just what? You're going to go present yourself to an emergency room? What are they going to do? Give you Haldol.
This particular compound, ketamine, in more of a therapeutic context for these kinds of people, because the people that need these ganglion blocks are very likely the people that need lots of other things too, right?
It's a pretty serious deal. I mean, the latest studies are like, we're probably losing 40 veterans a day under the age of 65.
Welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. So today I had the honor of interviewing Dr. Johnathan Edwards. I've known Dr. Edwards for many years. He and I met at least 3 years ago now, and he's one of the few people I know that's still dancing around conventional medicine and alternative medicine and doing some amazing work. He also knows Dr. Ted for many years as well. So here's a quick bio on Dr. Edwards. He's a board-certified anesthesiologist who treats chronic pain patients of all types: NFL athletes, UFC athletes, motocross racers, cyclists, and more. He is the author of several books and medical papers, including Revolutionary Ketamine, Chasing Dakar, Suicide, COVID-19, and Ketamine, and The Science of the Marathon, along with a new book on pain that's just coming out now. He practices medicine in Las Vegas, Nevada, and Port Orange, Florida. He's a native of California. He studied at Victor Valley Community College, the University of California at Davis, and earned his medical degree from Eastern Virginia Medical School. He went on to study internal medicine in Vegas, physical medicine rehab, which he hated, in Utah, neurology in Lyon, France, and then completed his anesthesiology residency at University of South Florida. He lives with his wife and daughter in Port Orange, Florida, and also part-time in Provence, France, where he owns a home, and he is fluent in French. So Dr. Edwards and I had a really wide-ranging conversation about multiple different topics. We started talking about some of his work in interventional pain management, including stellate ganglion blocks. These are very cool, very interesting, very crazy that they used to do them without any ultrasound guidance before that came around as something you could actually do. Talked about it for sympathetic overdrive and how really it's important not only to think about it on its own, but in the setting of psychotherapy and overall therapy, and not just the stellate ganglion block. And then we talked a lot about ketamine. We talked about mechanisms of action. We talked about history, talked about buddy shots during Vietnam. I thought this was morphine, but evidently it's ketamine. Interesting, at least not just morphine, but ketamine as well. And we spoke about the use of ketamine in treatment-resistant depression, talked about various protocols associated with treatment-resistant depression, PTSD, and others. Mechanisms of action, we circled around several different times, talking about GABA and glutamate specifically. Then in the end of the interview, we talked about his work in percutaneous hydrotomy and some really interesting ideas on how this works for pain management in a much different way than anybody would think of, including me. I didn't think it'd be so simple as a potentially diffusion problem or diffusion issue, and that we could override some of the issues with pain just related to diffusion itself. I really hope you enjoyed this podcast with Dr. Edwards. Please can subscribe below if you like our podcast and share it with your friends and family. Enjoy. Hey, Johnathan, how are you?
Great. It's awesome. Awesome to be here with you.
Yeah, I'm excited to have you. I know we've known each other and you've known Dr. Ted through other channels for a long period of time already. So it's great to have you on the podcast. It's great to have you be here and talk to us. And so where I want to start today is on some of the cool things that you're doing that are really outside of what people think about when they think about an anesthesiologist, which is what you are. The first thing I want to talk about is what the hell is a stellate ganglion block, and why the hell should we be doing this?
It's in our wheelhouse. A stellate ganglion block is basically the cervical thoracic ganglion. So it's that sympathetic ganglion that lives in your C6, C7 nerve. They're sensory nerves, right? Autonomic nervous system nerves. And it lives right by the longus colli muscle, right there by where the vertebra comes off. And what's done used to be a blind block way back in the day when I was doing it or learning it anyways. Yeah, no, you had to know your stuff. But anyways, not all the blocks were successful. So, but getting back to what it is. So it's a block. It's exactly what it says. It's using local anesthetic and other substances to place around that area of nerves to calm down if you will, the transmission of the nerves that feed into the vagus nerve. And that's the whole idea behind it. A little bit about the history of it. I think we've been doing this. Actually, I was looking at the history of it. We've been doing this for several years, at least since the 1960s, I believe, if not earlier. And originally it was used for Raynaud's phenomena, hyperhidrosis, extreme sweating, and then it mediated into complex regional pain syndrome, reflex sympathetic dystrophy, those main things. And then it went into treatment for like stress and PTSD and mental illness and all these things. And so it's at a genesis of many years and several indications. And it's easily done by ultrasound nowadays, especially from an anesthesiologist point of view, because that's our territory for placing lines and I do other blocks. I do the interscaling blocks. I do all those blocks associated with the shoulder. We do blocks for carotid endarterectomies. So that's near and dear to me. And so I love doing those blocks, and they're very rewarding.
Yeah, let's talk about that. So I think that's where I learned about the stellate ganglion was in PTSD and trauma related to the wars in Afghanistan and Iraq, and some veterans coming in. What's your history there? What have you seen?
I've seen the veterans I've seen some amazing results, and I've seen some people with no results, to be honest. I don't think it's like anything else. It's not the magic bullet but the stellate ganglion block, and somebody with PTSD, like who from Iraq or whatever, if they're like really high on the PTSD scale, they're suicidal, those kinds of things. And I think it's a good time to bring up. It's a pretty serious deal where the latest studies are like, we're probably losing 40 veterans a day under the age of 65 to suicide. So anyway, I've seen plenty of veterans get these blocks and do these blocks, and it has a very profound change in many of them. They just calm down. It's like they say the pressure's lifted off their shoulders, and much almost the same way as you after a psychedelic treatment. In fact, that's what's interesting about it, except they don't go into any psychedelic space, but I think it calms down the sympathetic outflow to the point where I think your parasympathetic outflow just takes over, and you're just in a relaxed state that you never thought you could put yourself in. And
is that better? Have you seen it work better with therapy together?
Yeah, no, it definitely works better with therapy for sure. And I think that's one of the powers of it, actually. I think in the same way, as we'll go into in a bit with psychedelics and other medications, the stellate ganglion block can be paired very well with therapy. And I think make therapy even more possible than it was if you didn't do the block. So that being said, and then there are risks to it, though. It didn't happen to me, but I've actually seen discitis from one of these blocks.
Have you? Okay.
And they had to be treated with IV antibiotics for months and months. You're close to a lot of delicate real estate when you're doing these blocks. That's why the ultrasound
makes it more fun for anesthesiologists, right?
Yeah, for everybody.
Yeah, for sure. Yeah, and that's certainly what I was considering when I found out where that you were injecting this needle into somebody's spine, into this area. But certainly giving a relief or a respite from sympathetic over craziness that can happen in these people seems to be very helpful. What exactly are you typically injecting? Is it just
usually 3 to 5 cc's of local anesthetic nowadays. They used to do it like with 10 to 20 cc's because the needle was blind and you weren't sure where you were. So you do a high volume. But nowadays you can use a lower volume because you can actually see your needle where Chassaignac's tubercle is, and you should be able to see the atlas muscle, and then you can see the vertebral artery. It's like you go in between the vertebral artery and the internal carotid artery, and then right in between that should sit. You go through one of the scalene muscles and then onto the coli, and that's where the ganglion sits. And then your goal is to inject just as close to that as you can. The goal is not to inject into the ganglion, but you just want to be around it. You don't want to inject into a nerve.
Right.
There's that, and then
lidocaine, or what are you using?
Usually traditionally done with that. I use like ropivacaine or bupivacaine, 0.5%.
Okay.
Yeah.
Gotcha.
And it's just
how long?
Yeah.
The effect itself can't be very long then, right? So it's more of just
it's hours.
The instant reset.
It's hours.
Yeah.
And then but the effects are experienced sometimes days to weeks to months out.
Yeah, it's pretty amazing. like a couple hours of not having sympathetic response can do such
Yep.
significant work for some of these people.
That's the amazing part of it, to be honest. It's usually you got to
Yeah.
repeat it or something like that. And then lately, though, I've been exposed to, I listened to this one Dr. Khan guy, I think his name's Adele Khan. He works with Tony Robbins, all these sheiks, and probably doing way better than we are. Anyway, he's
Sure.
injecting exosomes into the stellate ganglion, or like local anesthetics plus exosomes, or maybe, I don't know. I don't know the exact things. And I looked it up and there's no studies on it. I can tell you that much, at least for what I saw.
Sure.
But he's one of these stem cell guys and really into it,
Yes.
and has done his fellowship, and he put stems. I think he'd probably put, I don't know, probably put stem cells into your fingernails if it would help.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training doctors and practitioners on how to optimize health rather than treat disease. For this particular episode, check out the chronobiology module, where we talk about circadian rhythms, we talk about light, we talk about sleep, we talk about disorders of sleep, and how you optimize metabolism and optimize sleep together in a holistic way using our processes and framework in health optimization, medicine, and practice. Go to homehope.org and use code POD10 to save 10% on this module or any module of the Essential Certification or our advanced practice modules. Now back to the show. Sure. But anyway, that's the other thing.
But he says that he really notes the good effects he's having with it. And is there an anti-inflammatory effect at this level of the stellate ganglion that's making a difference? Quite possibly.
Yeah, that's super interesting. I think maybe there's a natural next part of the conversation, even though I wanted to go a different order when we first started, would be talking about the ketamine experience and the sort of the therapy experience. Because I know you spent a lot of time with that, first as an anesthesiologist, of course, and then as somebody that was using this particular compound, ketamine, in more of a therapeutic context for these kinds of people, because the people that need these ganglion blocks are very likely the people that need lots of other things too, right? They're not just going to, as you said, most people will benefit from a stellate ganglion block, but it's not going to be the sort of permanent fix for most people. It's going to be something that's going to help them along that path potentially as they're looking at other ways to help to recover.
No, it's a multimodal approach. That's for sure. That's in this bit in that business. There's no one magic shot as anything in medicine. It's multimodal.
Yeah. So tell me, let's talk about ketamine. So I know you've written a book on it and you've interviewed a lot of people on ketamine itself. And let's talk about first a little bit about the mechanisms of action, because I think a very strange drug and how it works is still being worked out. If you want to give me get a little history on ketamine, how it came about, I think let's focus at least initially on how it's actually working in the system as far as we understand it.
All right, great. I'm glad so in chapter 2 of the revolutionary ketamine, I start off with the genesis. First, it was in the 1960s. It was an experimental drug in response to a drug called phencyclidine. And phencyclidine caused
PCP.
Yeah, it's an angel dust, right? So that caused some serious postoperative delirium to the point that the anesthesiologist back there was like, hey, we can't use this. So the goal...
Were they trying to pick up cars or throw...
yeah, that's
the PCP stories, right?
We'll get more into that. But their main deal was like the post-op delirium. So they made this drug called CI 561 at Wayne State University, and they developed it, and ketamine was born. And it turns out, of course, back then you could use it on, you could do all these experiments on prisoners. So the first subset of people who got the ketamine was 20 prisoners, and they all tolerated it magnificently. What they found was it caused a dissociative state. But there was no respiratory depression and no blood pressure aberrations at all, which was unheard of for an anesthetic at that time. And even today it still is. So given that, and then it was just making its way through trials, and it still wasn't FDA approved yet or really for use. And then came the Vietnam War. In the Vietnam War, they found it was a great buddy drug. Like you could give somebody a big dose, somebody who got shot, whatever, broken bones, compound fractures, and you could get them out of their head, not need oxygen, not need any respiratory devices, and it wouldn't have really affect their blood pressure. And you could get them the medical help. And then they would probably get more ketamine once they got to the MASH unit.
So this is like, how would when you say a buddy drug, tell me what that means. People would be carrying it around so they can inject their buddies if they need to?
Correct. You carry it on you, and if your buddy's shot, you give it to them, and you can get them to safety.
How much were they giving? Do you know what kind of dosing they were giving?
I don't. No, I don't know exactly. It's at least 100 milligrams or so. They were probably given like half to a milligram per kilo.
Gotcha. Yeah. Okay. Continue with
Yep.
your story.
So,
Sorry. I was interested.
so that's how it got pushed rapidly through the FDA. And then it got into hospitals in the 1970s for medical use. There was and it beat out all the other anesthetics. And so it was widely used back then, especially for kids and things like that, and setting bones and all. And it's interesting. And then it was really popular. And then in the 1980s, propofol came along, and propofol was just turned out to
Mhm.
be a much cleaner general anesthetic. No, and it didn't have any post-op delirium. Ketamine still had some, but nothing like the
Yes.
PCP, right? The
Yeah.
phencyclidine. So from there, ketamine it was still used in the hospitals, even in the 80s and 90s, but it became a drug of abuse. So you might have heard the terms kitty smack or like poor man's heroin, something like that. And in Asia, so you got a lot of abuse with it. And the discussion around ketamine, it started to envelop around that, which was a big problem. But it's interesting that, so in Asia and India, it became big problems, also in Russia, to the extent where Vladimir Putin banned it outright for all humans and animals. And it wasn't until
Mm.
Brigitte Bardot, who was a huge animal activist, wrote to Putin and got him to reverse the whole thing. So anyway, so it's still used for that. So in the 90s, though, then if you remember, there's always these crises, mental crises, that if you can look through the 70s, 80s, and then the 90s, if you remember, it was bulimia and anorexia. So some
Mhm.
UK researchers started trying ketamine in low doses to see what it would do with bulimia and anorexia. And to their surprise, they found it helped. So they stopped the episodes and helped some of these young girls going through this. And it was all girls in the study, actually. And then at Yale, the researchers there, John Crystal, Dr. Berman, and some others, started using it on depression and suicidality. And then they came up with the will to live, or the I want to die, I want to live study. And they gave it to a bunch of suicidal patients and found that a huge number of them went to the I want to live side. And that's where it was birthed for. And at that moment, it became the first medication in over 50 years that came in the mental health space. Before that, it was
Mhm.
SSRIs. As that came from the tuberculosis drug, imipramine. They gave it in the tuberculosis colonies, and just they all had increased activity, better mood, and decreased depression. That's where the SSRIs,
That was a TCA,
TCAs,
right? That was a
tricyclic antidepressants.
yeah.
Yep. And from that came
Yeah.
so
Sure.
anyway,
Sure.
but
Gotcha.
that's the genesis of it. And then, yeah, since then,
Let's talk about the mechanisms. Let's talk about I want to get more into sort of therapy and how it all works, but I think that's a great overview. I knew about the buddy drug thing, and I remember like watching video
yeah.
movies of Vietnam where you go in like somebody was shot, injecting them with something, and I always thought it was morphine, but I guess
No,
sometimes
a lot of them did use
yeah,
morphine, because remember, the heroin was
okay,
like heroin addiction was huge. So they got
yes, it was
morphine as
big during
well,
that time.
but no, ketamine was the deal. That was for sure.
Ketamine was a deal.
So,
Okay, that
the
makes a lot of sense
mechanisms.
now.
So the
Yeah.
mechanisms of ketamine.
Yes.
So
Yeah.
basically,
Yeah.
first thing I want to say is ketamine is a psychedelic. It fits all the criteria to be a psychedelic. It fits the oceanic experience. It fits the loss of ego, the loss of recognition of time, can put you under the multiverse. All the psychedelics do that to one extent or another. And it's research semantics that basically places MDMA and ketamine, quote unquote, outside of the psychedelic medicine realm. But when you talk to psychiatrists, and I've talked with many, everybody says hands down, sorry, ketamine is a psychedelic. That's how I feel. And that's what I wrote about in the book. I'll just leave it at that. There are studies showing it actually does touch the 5 hydroxytryptamine alpha 2 receptors, which makes the psychedelics. So anyway, we'll leave it at that.
Right.
So
Yeah.
ketamine blocks NMDA receptors, so the N-methyl D-aspartate. And what does this do? It increases glutamate. So you have the neurotransmitters glutamate and GABA. So glutamate is important, and you can have a whole podcast on glutamate. Books have been written about glutamate. I think the easiest way to think about glutamate is the reason your mind can go back and ride a bicycle after years of never having ridden a bicycle before. It helps bring back that functionality of your motor and sensory, your equilibrium.
Mm,
So that's how important glutamate is. So it's an
mm.
excitatory, right? So it excites certain parts of the brain, especially the hippocampus, the amygdala, all the prefrontal cortex, all those things. So ketamine increases glutamate at its base by blockage of these NMDA receptors. Go ahead.
So what else? That's the start there. Is it working just on
No,
glutamate then?
nope.
Or you talked about
It
the GABA glutamate ones?
also modulates the inhibitory neurotransmitter, which is GABA, gamma aminobutyric acid. So it balances that. So GABA is increased with the balance in glutamate, because if you have glutamate overload, that can actually overstimulate the brain and
Right.
cause even damage. So I think so the whole GABA, it's almost like the sympathetic action of the brain, really. You got the excitatory and the inhibitory. Same thing with the sympathetic and the parasympathetic. It's kind of how I look at it. When you have mechanisms in your brain putting on increasing the accelerator and putting on the brakes, and they balance out each other. Yeah.
So are you saying that with ketamine increasing glutamate, it's also, as a result, in balance, increasing GABA as
To some
well? Is it doing
extent,
it
yeah.
by...
It doesn't increase
Yeah.
GABA to the
Okay.
same extent, I think, glutamate. That's where you
Got
get
it.
in the weeds, to be honest. You start reading
Yeah,
some
and
of
it gets a
these
little bit
studies and
tricky.
it's like, oh man,
Yeah.
it's all based on fMRI. And at the end of the day, it's still looking at shadows. You're just
Sure.
trying to look at shadows. So anyway,
I understand. Okay.
so yeah.
So you mentioned the hippocampus. Is that the specific area where we're seeing most of the activity when we're using ketamine, or is it throughout the brain that
Prefrontal
you're seeing
cortex
activity?
is probably the main part, and then you also,
Okay.
and then the hippocampus, and then I'd have to go back into the fMRI studies to really
Okay.
look exactly. But those are most of the areas it hits, mainly when you look up what lights up.
So you mentioned the psychedelic experience, and just to go back to that for
Yep.
a minute, and then of course it's being used for anesthesia much longer than it's been used at the lower doses for these psychedelic experiences. Can you talk a little bit about the dosing and what changes, or if we know what changes, or why a lower dose would be more psychedelic versus a higher dose that would not be psychedelic?
Yes. So that's a great question. And I go through all that in chapter 8 of the book, where I talk about what's a psychedelic experience, what's it about, those kinds of things. And I go all into that kind of stuff. And basically, in a nutshell, 0.5 milligram per kilo over 45 minutes is the standard at which John Crystal and others used to do their studies intravenously. So that is important, because under that experience, you do not go all the way to sleep. You are not under anesthesia. You might touch where you're loss of time. You might touch where you're loss of ego. Certainly you might little touch that you're seeing colors and those kinds of things. But then when you go past that, you get into what's called a multiverse. And then when you get past that, it's called the K-hole. So that's more to do with illicit drug use. So I think the goal is to touch between this kind of sub multiverse, if you will, and keep patients in there, because that's where your ego is extinguished, as well as your fears. The whole goal of going into a ketamine experience is like, one of the reasons most people can't do therapy is because they're triggered. Let's go to an extreme example. I don't know, somebody got raped or had a gun pointed at them, and they're, even just the thought of it, they just start sweating. Their sympathetic nervous system, they can't think anymore. Their minds just race. Imagine being able to do all that, think about all that stuff, and be calm about it. And that's what a psychedelic experience, and because I don't want to just put it to ketamine, all of them can do that. Psilocybin at the right dose, ayahuasca. That's why all these people come out of these experiences going, oh my gosh, I didn't know it could be that way. There was a story about on Dave Asprey's once, I caught my eye. One of his assistants had a huge needle phobia. Somehow they got the line in her. But after the ketamine, she had no more phobia of needles at all. It completely extinguished them. So, so I think it allows you to look at those fears in a reasonable way, safe way, and allows you to deal with them. And then it's important to talk about some of the other proteins that are upregulated and why it's fertilizer for the brain, and then why it helps therapy so much.
Do you want to go into any of
Do
that?
go.
Yeah.
So I was speaking with, so one important study to highlight is Lori Calabrese. She's a psychiatrist out of Connecticut, and she did a population of 235 suicidal patients, young from 14 to 70 something, I think. They did 3 treatments, and they had really good therapy. Mind you, all these studies, you have to keep in mind, they have top-notch psychiatric therapy. That's hard to get and hard to pay for, as I'm sure.
Yes.
So
Every anesthesiologist with their shack, with their little, they're on the side of the corner saying they can do anesthesia.
exactly, that's the therapy world. So just remember, in every one of these stories, they're getting top-notch therapy. So anyway, she showed that over 80% of these patients who got these series of ketamine treatments had abated their suicidality, and not a one of them went on to die by suicide or commit suicide.
Wow.
Not a one of them. And she showed this in an outpatient clinic setting. She was pretty much the first to do so. She's a huge pioneer. And I got to talk to her at the Metabolic Health Conference. And one of the things she says that will make sense is that ketamine is like fertilizer for the brain. Why is that? Because by manipulating the glutamate system in the brain, you also upregulate the BDNF, or brain-derived neurotrophic factor, and you also upregulate mTOR, the mechanistic target of rapamycin, which, as you know very well, increase neuroplasticity. So by increasing this neuroplasticity, you can help augment the therapy to get your brain out of the default mode network. It's that rut that your thoughts are stuck in that keep leaving you in PTSD, depression, suicidality, all those mental things that hold you back and basically why you're seeking treatment. So that's what a ketamine or a psychedelic treatment does. And it's so important to think of it like that. The default mode network is key. And then
we talk about the default mode network a lot, and how it's our stories, it's our patterns, it's who we think we are, and how psychedelics, when they're done, can help you get out of those tracks, right, that you've left for such a long time, and be able to clean them up. And it sounds like her description here is fertilizer. So you're basically able to create new ones.
And then she's been great. I think she also said that like ketamine in some cases is like doing 6 months of therapy. Like they see that it pushes the therapy ahead by 6 months than they could have otherwise with just therapy, assuming somebody stuck with it. So, I mean, those are the success stories. And every time I talk about this, though, I always want to make sure I go on the other side. There are folks that are not helped by ketamine or anything. And I just got to keep that in mind. It's a miracle for a lot of people, but not for everybody. And you should I just like people to keep that kind of thing in mind.
So I have a question for you. I don't know if you know the answer to this, but it's okay. But as far as the anesthesia dose.
Oh, yes, we got it.
Is it just you're going into a K-hole and you're just in like blank space and that's it?
Before I answer that question, you asked another question that I wanted to get into. Does a deep state of ketamine do the same as a light state of ketamine? The answer is no. When you put somebody too deep, they actually don't get the mental illness benefits that we see with the lower doses. Like some people might need a milligram per kilogram, 0.7 milligram per kilogram, given slowly, or intramuscular, it depends. But when you start going into like general anesthesia doses, like 2 milligrams per kilogram, or even 3 to 4, those are general anesthesia doses. And those put you into general anesthesia land. But your guess
is that because I was just wondering if it was just like a massive K-hole, or
that's a good question. I think
that
you definitely blow past it, because a lot of people, but it can put you in the K-hole.
You're not aware of it.
You might not be aware of it, but just before that, I'm sure the K-hole exists. And I can tell you, if you don't prepare somebody for this, they are terrified. And so I've made it into my practice. I don't care who I give it to. I go through like a 10-minute spiel of what to expect, to how know they're safe, what environment they're in, and I don't care where they go in the journey, that they are safe. And when I do that, everybody seems to be okay. All the horror stories you hear about ketamine are people like in the ER, and they just bolus like 100 or 200 milligrams right there and then, and people wake up screaming, terrified. It's like not. It is not a pretty picture, and they'll have nightmares for days afterward. But I've found
Wow.
There's
Wow.
another way to abate that by giving a benzodiazepine along with it. That helps a bit.
That's what I was wondering. I was wondering because if you're going to be giving somebody ketamine for anesthesia, as they're going through that process, it might be relatively quick, but you're going to still have some of that on ramping where they're going to get the anesthesia
Yeah.
dose. So you can mitigate that by
Benzo.
either giving them or you can give them something like a benzo or
Yeah,
something
and
like
it's
propofol,
never,
I would
yeah, and
imagine.
you're always giving propofol with it or the anesthesia gases. It's never just ketamine, just like we never, only in EGDs do we just use propofol, right? So it's pretty rare that you just use a single modality to achieve general anesthesia anyway. Yeah. So I
Gotcha.
think I would
Yeah.
say to the final answer to your question there is now they're in anesthesia land. Probably, you're probably not aware in any way, shape, or form of what's happening in your brain while somebody's
I
operating.
got that. And of course, and there's the other drugs that are also on board too that are also suppressing as well.
Yeah.
But I know you interviewed a mutual friend of ours about his experience in the ER using ketamine. Maybe you can give us that
Oh
story
yeah,
real
so
briefly. 'Cause
even
I think super interesting.
super
Yeah.
interesting. Yeah, so that's why I was so glad I put that in the book too. It's in one of the later chapters because the the important thing to highlight here is that many top thinkers like Thomas Insel, he's the former head of the mental NIH, so the Mental National Institutes of Health, and when I interviewed him, he said his hope is that ketamine by the year 2025 is standard of care in emergency room to be able to give to suicidal patients with the hope that you don't have to institutionalize or Baker Act them and that they could actually be sent home with a follow-up therapy prescription safely. And there's been many studies to this effect with
Out there.
success. And so what happened with
Sounds much better than Haldol.
yeah, Haldol's Haldol. It's like
Ugh.
it's such a bad choice, but it's the only thing we had, right? So
Yeah.
so our ER colleague, he had a patient. I believe she had a forearm fracture or something like that needed to be sedated, or a wrist. It was a wrist, like a radial fracture, radial. So he's able to set it
Sure.
in
Sure.
the emergency room, and he knows all about ketamine, and he's just on the up, and so he knew what it could do. So he used, and as he does often, and he explains to the patient, hey, this is going to put you in another place. You might meet people, you might meet dead people, loved ones, things like that. And he gives her the sedation. He sets the wrist, puts the cast on, and he said she woke up with a smile and looked at him, and with the most powerful way of saying, she just said, "Thank you."
Yes.
And she was just so thankful that she underwent this experience because it was healing for her, she said. And you would never get that with propofol. You would never get
No.
that with Ted and fentanyl kind of thing. People just get sedated and it's almost like they're having fun with it. Ketamine is a serious journey, I think. I've done
Yeah.
it. I actually
Sounds like
did it
me.
once and it was an interesting deal. I did it in the clinic,
Yeah.
but
Was it?
I'm not afraid to talk about it. But it's a journey and I'm not going to call it like getting high or having fun it's a serious deal where you're face to face with your own thoughts and what's in your mind, great colors, all that kind of stuff. And I'll just say, yeah, I traveled, I had no sense of time. But the thing I came back with it was I knew even if I left this world, my family, my daughter, my wife was going to be okay. I couldn't explain why. I just had that sense of confidence after the treatment.
Yeah.
Yeah.
That's a very common experience with all psychedelics is that you come back from your journey feeling like everything is okay.
Exactly.
And that's
Yeah.
obviously why it's been studied in people with cancer and with terminal diseases. And that's with the psilocybin studies and MDMA and things, but especially psilocybin, I think has been studied this way or is being studied this way. So it's very exciting that we can use these kinds of compounds in this
Well,
capacity to truly help people feel
for the
calmer.
first
and
time in
feel,
60 years, with a 60-year
yeah,
hiatus, think about it, of psychedelics. And it was
that's
all
been a long
thanks
time.
to Harvard people like Timothy Leary saying, tune in, tune out, get out. And instead, it should have been tune in, tune out, grow up.
Yeah, there was a slight change. If he had made it, it probably wouldn't have been as countercultural, maybe, but it would have been made more sense
Yeah.
because the way that we think about psychedelics, at least and Home Hope, is that the ideas that you were describing with ketamine earlier, which is the neuroplasticity aspect of it, right? The
Yeah, I
psychoplastogen
appreciate you guys
aspect
so much because
of,
like you know about
of
it,
yeah,
Ted knows about it,
yeah,
and they all
yeah.
I'll read right now. So
Quote,
Ted's
yes.
quote on my book,
It's a good quote.
man, it was, which he wrote, and praise for ketamine. This is not a new drug. Oh man, I'll find it. I'll have to find, wait, just give me one. At the top of a mental hill, ketamine is like a fresh powdered snow that falls on, fills, and erases the well-worn deep ruts downslope and allows you to sled into original path of mind not yet taken. Ted Attuoso, CEO.
Yeah. Ted's got a beautiful way with words, but he's right in the sense that what ketamine can do and a lot of these plastogens can do is regenerate or give your brain the ability to create new
Yeah.
connections and to start over to some
Yeah.
degree.
It's
And
it's
as
a
you were
good
mentioning
reset.
earlier also, yeah, and as you were mentioning earlier too, John, about how you're able to process emotions without actually having to relive the emotions. And that's huge for ketamine. That's huge for MDMA and psilocybin if you get the dosing right, which is a little bit trickier in
Yeah.
general. But what do you think about oral dosing of ketamine versus IV? There's
Well,
troches,
the
obviously. There's
standard of
IV.
care is IV. That's just all the studies
I
are
know
done
that,
on
yeah.
that. And then you have intramuscular. So those have both a 99, 97% uptake respectively. Then you go to oral and nasal. And I guess nasal is pretty easy. It's a high, fast uptake in a spray, and it can be used. And you have the Spravato from the Janssen Pharmaceuticals, who they FDA approved it for
Right.
depression, and that's what's used for that. Then you have the troches. Now, the troches are interesting because they open up access. Who can no insurance pays for ketamine infusions or injections, not for mental health
Right.
purposes anyway. So neither for troches either, but troches can be sent to companies, from companies like Better You Care, I think KetaMD. There's all these companies out there.
Any compounding
Compounding
pharmacy
pharmacies make it, and you can have it
Yeah.
sent to their house. And most people send it like this. They send the troches, a blood pressure monitor, face mask, I think even oximeter, which from a medical point, it is good to have those things. But as we said, ketamine you don't need oxygen.
You don't have any respiratory depression. Yeah.
If you take it at the proper doses, and we can,
Of course.
and
Of
then
course.
we
Yeah.
can get into that part too. But anyway, so I think oral ketamine can have a great effect. Australian researchers showed without a doubt it can stop suicidality. It can help PTSD. It can help depression. It can help. And the most important is treatment-resistant depression. That's like the real hell. It's basically when you're going through depression longer than, I think, 6 to 8 weeks, and you've tried 4 different types of antidepressants and nothing works. Or no, I think it's much longer than that actually. But anyway, the antidepressant you are taking does not work, and you're just in a chronic state of depression, and you're just choosing a suicide date at that point for many people.
Yeah. So I know that during the pandemic, it became pretty popular for some of these services out there to do exactly what
Yeah.
you said, have troches sent to people's houses, do therapy remotely. Do you have a sense of how effective that is or how it has been? Or I know these companies raised a lot of money to be able to do this, but I don't have a sense of the effect, if we have any idea of how effective
I
it is.
think it was effective for a subset of people. I think there's people who
Okay.
abused it, obviously. That's just nature of these kinds of things. But I think overall it helped, because I was actually working with one of these companies, the Better You Care, with Dr. Sam Zand and Derek Duchesne, and they run this company. And I was actually seeing many of the medical charts, because I was helping basically it's the PAs and nurse practitioners doing a lot of the therapy, to be honest. And it's funny, they can just get done with their training and all of a sudden call themselves therapists, and it's all good. Where if we did that with the medical board, I don't even want to get into it, but it's just a sad state of affairs. But anyway, I was reviewing hundreds of charts, and I could actually see the changes from good things were happening overall. And so I actually got to see it firsthand. And I would say, like I said, from an access to care standpoint, you live in rural North Carolina or wherever, and you can do this at your house, I think that's a good thing. And I think it should be supported, because if you look at the suicide rate in 1 year, it's over 50,000 last year.
That's great.
The overdose rate's 110. Just 4 or 5 years ago, it was 70,000. There's a lot of people hurting out there. And just because you don't want to go to and you have a depressive episode that's that bad, and you're just you're going to go present yourself to an emergency room. What are they going to do? Give you Haldol and maybe put you in the psychiatric ward and then get you some therapy while you're under sedated with Haldol and benzos. And you're just going to be so zonked out. And if you say you're suicidal, you're for sure going there.
Yeah.
So I like this change, and I have my own opinions about it. I think we could do much better as a society just by, I don't know. I always say, imagine if everybody just sat at the dinner table and talked things out. We don't do that anymore, right? It's powerful. Anyway, it's one of
I appreciate the perspective. I think I love the idea how you could transform emergency rooms and the psychiatric aspect of these things and see such potentially huge benefit, and at least acutely, and then more long-term having options like the ketamine troches, I think it'd be very powerful for a lot of people. I do know that it's very expensive to get something like the Bravado, the nasal spray, but it's very cheap to get ketamine troches, for example, as a comparison.
Yeah.
A lot more affordable. What's your sense of people looking, if a clinician is looking to refer to somebody to get ketamine, or if a patient is directly looking to get ketamine therapy, what should they be looking for in a clinic that will make them feel more comfortable that it's not just another anesthesiologist that's hanging up their shackle and saying,
not just that.
Yeah.
It's nurse practitioners and nurse anesthetists. And a lot of these people are just hanging a shingle out going, hey, come here. They give them like, super high doses or what. It's not to say it's all bad, but my concept is it has to be connected with therapy. If you don't have a therapist, I'm going to get you one. And that's why I work with the psychiatrist, Dr. Sam Zand. We've been working together a long time. He's taught me a lot about therapy. I've taught him a lot about ketamine. It's been a great mutual relationship. And I'm really strict about that. And I believe in it just from all the studies I've read. And after talking to people like Lori Calabrese, or Dave Feifel and out of San Diego, it's got to be done right. And a lot of patients will come to you, oh, I just want the ketamine. Just give me the ketamine. And I just shake my head. No, that's not how it's worked. It's like, just send me the nitroglycerin. No instructions.
Like that comparison,
right?
The drugs. It's about the drugs. That's how a lot of people feel. But I know I appreciate that because that's what I always tell people that are asking me. I'm like, look, you have to make sure that you have a therapeutic opportunity here where you're not just getting the IV ketamine, where you're actually going to see a therapist. You're actually having follow-up and integration. And what is the typical protocol? I know there's multiple. What's like the standard treatment-resistant depression protocol that we have at this point that we
like 1 to 3 treatments usually to start off with weekly therapy. You'll get a treatment every 2 weeks if it's depression. If it's suicidality, stories are better. But one girl, she had really, ever since she was a little kid, her name, it's a story you can find on the internet. And I talked about it in my Speak Health event, it's a TED Talk basically. And that's easily found on YouTube. I spoke about this girl's name is Olive, and history of PTSD, bipolar, depression, suicide attempts. By the time she lived through it all, and by the time she was 26, she decided the best route forward was to sign up for assisted suicide in the Netherlands, and she'd already paid for it and bought her ticket. So the day she was to leave, her friend talked her into going to this clinic in, I believe, Sarasota, Florida. And I actually talked to the clinic and they told me all about the story. And she got 3 treatments in that 1 week of ketamine and she never looked back. She never took that flight. Anyway, it just highlights if you're suicidal, you might get a barrage of treatments within a week, where if it's depression and it's more controlled, you might wait once every 2 weeks or once a month, or depending on what the recommendation is. Usually the psychiatrist will have a good idea of when that should be done based on the therapy. But I would say that's the difference between the two.
Gotcha. Okay, so let's finish up by switching gears a little bit. It's something that not very many anesthesiologists do, but you have brought this technique over from places around the world. And I'm interested in it because pain management is not an easy thing. And a lot of anesthesiologists are working on this, and it's hanging up the shingle and just saying, hey, I can do pain, right? It's not the same thing as actually being able to do things in a holistic way. And so let's talk about what percutaneous hydrotomy is and why you got interested in it in the first place.
It sparks. I actually graduated from medical school thinking I was going to do physical medicine and rehab, and with an emphasis on sports medicine. And then, so I did a year of internal medicine, which they tried to get me to stay. And sometimes I look back, I would have been an oncologist. I loved oncology. But anyway, I got into PM&R. I did that year at University of Utah, and I hated it. And part of it was the faculty and all that. But the bread and butter of PM&R is truly stroke rehab. And I was just like, when you're in residency, you're thinking about whatever I'm doing here is going to be the next 30 years of my life. And I thought, no way. So anyway, I quit. I finished the year successfully, got the year of credit. But in the meantime, I had an offer from the French ambassador through a friend connection. He offered me to go do neurology and research in Lyon, France. So I went to France for that year. It's because my dream was always, one of them was to live outside of the United States for 1 year and learn another language and a culture. And so I achieved that all there, and it was in my early 20s.
Mhm.
And I'd always maintained a connection with France, and thankfully I learned the language well enough that I was still the doctor for bike races over there. I was still, I was doing the Dakar rally, all in French. And then at one point I had a French fiance, and I was living in the family. So my French has always been very good. And to this day, I don't know why I don't have an accent, but I don't really have an accent. It's crazy. Anyway, so the point is I've always had my foot in France. I bought a house, raised my daughter there a bit. And then I got exposed to mesotherapy. So percutaneous hydrotomy, in short, is, you heard of mesotherapy. They're basically subcutaneous injections of certain medications and vitamins sometimes over the area of where it hurts. Percutaneous hydrotomy is really just mesotherapy for musculoskeletal pain. That's the easiest way to think about it. And I went over, I trained with the founder who trained with, you may have heard of the Dr. Michel Pistor. He's the founder of mesotherapy, and it's huge in France. In America, we think of mesotherapy as an aesthetic deal, like to the fat dissolving stuff, right? It's not that at all. It's not that. It's it was actually designed for pain, period. That was its first indication. And that's what the French government and their social security pays for. They don't pay for the aesthetic part. They pay for how it helps pain. So think about, say, percutaneous hydrotomy is just what it sounds like. It's through the skin. So it's subcutaneous, just like mesotherapy is. And it uses the power of saline, uses minerals, vitamins, anti-inflammatories like Toradol or ketoprofen, local anesthetics like ropivacaine or bupivacaine, and dilute steroids sometimes, medications like pentoxifylline, which can help vasodilation. And you do it all over the areas of pain. And basically, you're just filling up the subcutaneous space with this solution. And by doing this, in a sense, you can now let that depot, it's like a slow release of medications into the localized area. And this is not anything new. They've been doing this with monoclonal antibodies. They've been doing this with Humira. There's good research. Koulakis et al. Did this out of UCLA, and they actually showed how big. Have you ever seen like a shoulder after an arthroscopy, or a knee, how big it is filled with saline?
Sure.
They're huge. And that's it. And we don't go up to that extent, but you can imagine it's the same phenomena. And when you do it like we're doing it, it might last for a couple hours. And then, so anyway, there's very good results, and there's almost no risks if you use a clean aseptic technique, and you're always using, and it doesn't hurt. It's just like, you might use tumescent anesthesia, which is diluted lidocaine with saline, and then you numb up the area.
Yeah.
And so now you have to think about what's going on. Are you treating the cells at this point? Are you treating the terrain? And it goes back to the whole terrain microbe thing. And actually, I argue in the book, you need both. And I think we're depending on too much of medications, where this can go into, you can actually look at this as a regenerative technique. And then if you go to the work of Roy Altman et al. Out of UCLA, he did a meta-analysis showing that just saline can actually treat pain. So there's all these studies that surround the mesotherapy percutaneous hydrotomy world that show this technique. It's an alternative technique, to be sure, but it has many studies around it that are solid. For example, in frozen shoulder, what is one thing We do. You actually give a steroid shot right in the joint. What you can do
Right.
with percutaneous hydrotomy, and I've done this to dozens of people now with frozen shoulder, including some very well-to-do. You basically, with a combination of local anesthetic, saline, magnesium, and a dilute dose of steroid, and you do 3 to 6 treatments like that, you can actually unblock somebody's shoulder. As you can imagine, once you do that, guess what? The rehab goes tons better. You can
Sure.
actually rehab it now. You can move it. I had a patient the other day. She had her shoulder pinned to her side. You couldn't move the thing. So I did the treatment, and she followed up with me the next 2 days later and said they were able to do so much more with me in rehab than I ever imagined. And she'd been dealing with this for months. Did it cure her frozen shoulder in one treatment? No. But you can see, again, it becomes multimodal, adds to the things you can do. For example, one thing I do with the motocross racers who come to me with injured shoulders, and I'm treating one right now, I'll do the percutaneous hydrotomy over the shoulder, whether it be a teres minor or whatever rotator cuff is involved, and then I'll inject PRP into the joint. So I'll use the both together to get an effect. And in some cases, yeah, it could render an athlete to be able to compete sooner than later. And good news is I actually ran this by WADA, USADA, exactly what I was doing, and they were A-OK with everything. They said, as
That's
long
great.
as you stay within the limits. So we made sure this was completely legal before and I've done this with the UFC fighters like Bo Nickel. He's a hot thing on the UFC right now. Gray Maynard. I've done it. I have a big story with TJ Dillashaw, and they've all benefited from these techniques.
I love that you're
Yeah.
combining them. I think that's super cool, John, because you're doing
Yeah.
obviously the percutaneous hydrotomy, but it's just one tool, a very
One
powerful tool in the
Yeah.
toolbox because what I love about it is that you don't have to inject joints. And that's a big problem, right? Because there's
Right.
not that many people that are skilled enough to be able to do that safely and effectively, even with ultrasound. And I don't think people like
Right.
me in internal medicine clinics should be injecting people's joints overall without guidance and things. Some people have been trained in this, but overall it's been like a weekend anesthesia course or something. So it's nice that,
Yeah.
that there is an option here for like a localized subcutaneous injection. I always was fascinated by the research on the saline that you mentioned before. I'm like, you're just injecting saline into an area that's not even the joint. Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision dose, precision formulated, and pharmaceutical grade formulas in the form of a buccal choky. For this episode, check out Tro-Z. Tro-Z is a comprehensive sleep solution. It'll help you fall asleep, stay asleep, and wake up feeling refreshed. We have GABAergic things in here. We have 5-HTP, melatonin. We have cordycepin, a fantastic derivative of a mushroom that increases your slow wave sleep. Check it out at transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. And these people are getting better. So
Yep.
what is it that's happening? What is it?
So is it the cells? Now you got to think about there's a phenomena when you have pain, it comes down, the cell is pissed off, right? There are things happening inside the cell, the interleukins, tumor necrosis factors, all those things that the bradykinins, all those things that cause pain are coming from those cells, right? Because that's where they come from. They just don't, it's not like they're coming out of thin air. They come from somewhere, and it is the cells at the end of the day. By allowing this slow depot of mostly saline, but you also have trace minerals, you also have anti-inflammatories, yada, yada, yada. But does that allow for uptake and dilution of some of these pain mediators?
Sure.
And there's some evidence to that. Is there any great evidence to that? No. I'm not going to sit here and say, yep, there's been rocket science, basic bench research done on all this. It's solid. No, that's not the case. And this has to be going to the cells, right? Because it gets the uptake is through the whole body, but those cells that are affected, let's say you have knee arthritis, the chondrocytes, some of that is getting to the chondrocyte.
I didn't think about it as a sort of a dilutionary mechanism, but why not? Because it makes sense, at least from a common sense perspective.
And I actually do show some basic science related to that. And I think the phenomena is the Embarge effect, or salting in, salting out kind of thing, where you change you've changed the salt concentration
Yeah.
or the
Totally.
osmolality extracellularly, and then that promotes the movement of water,
Yeah.
which freely crosses the membranes. And that's a known phenomenon. Is that what's happening with what we call percutaneous hydrotomy? It's a good bet, but that's one way I explain how the power of saline and water.
It's amazing. I love it. I can't
Yep.
wait to dig more into that, John, in your book. But before we get to where we can find you and some of the stuff you've done, I ask this question at the end of every one of our podcasts. And I forgot to give you a heads up. So I'll give you a minute to think about it. But I ask everybody, what are the 3 ways we all can live smarter, not harder? Smarter, not harder is the name of this podcast. It's the name of our umbrella company that supports our Transcriptions brand. And we have our nonprofit, of course, that runs this podcast too. So I know you have a very eclectic history. You've done a lot of things that have been outside the conventional box, even though you still, like me, dabble in the conventional world more than we'd like to sometimes. But it does give us more of a perspective than many because we can dance in all worlds. So given all that, in any capacity, what do you think 3 things that we can do to live smarter, not harder?
I think you could continue to learn another language, learn another culture, make yourself a world citizen. That changed my life in ways I could not have imagined, in so many unexpected ways. And even to this day, it's just my daughter's benefited from it, my family. And I can't stress that enough. Get out of your shell. So I'd say that's go learn another language. I'm going to harp on something I've learned a lot from like guys like Jonathan Pajot and Jordan Peterson, those kinds of guys. But it's something I also learned in France. Before I went to France, I didn't know the concept like this, learning how to eat at the dinner table. And it's something I talked about during the podcast. But if you can learn how to eat at the table and do it consistently, so much can be talked about, so much can be expressed, so much can be accomplished. Just imagine if the whole world just sat down at the table, how much maybe more love, peace, understanding would happen, especially in America. So, but that's one thing I got from living in France. I learned how to eat at the dinner table. And
I love that.
The command is à table. When you hear those words to a French kid, they don't question, they just come. So anyway, and then the last thing, I'm going to mimic something one of your last, Dr. Tween.
Taiwan, yeah.
He said, don't try to control the things you can't control. Man, you got to go with it, because we're all just specks of energy flowing throughout the universe. And if you try to force it too much, those ideas are not going to manifest the way you want them to. And ideas manifest through reflection and meditation. And then those ideas come out of you through the consciousness. And you have to go with that flow to be able to really think about them and accomplish and move forward the way you want to. And I think so, in a sense, that's expounding upon control the things you can control, but don't try to control the things you can't.
I gotcha. Yeah, I talk to my kids about that all the time. And most of the things you can't control, so why worry about them? It's one of my favorite Tom Petty songs too. And the Mark Twain quote. Most of the things I worried never happened anyway.
Oh, that's awesome. Yeah, right. That's right.
Yeah, I remember. I try to remind my kids about that all the time. But Johnathan, this has been great. I really do appreciate your time. Where can people find out more about you, what you're doing?
I got Substack, so that's on jonathansubstack.com. I've been writing a lot on there. And I have my website, JonathanEdwardsMD.com. I have at JohnEdwardsMD on Twitter and Instagram that I try to do. It's honestly, man, it's just too much sometimes.
I agree.
Yeah. But those are the places I'm searchable. You can reach out to me on my website. I have my email there, or Substack. Appreciate that, because I love writing about stuff and helping other people. And yeah, I just try to keep it real like you do. And I think that's why you and I like hit it off so well.
Yeah. And then just your books. Tell us about your books briefly.
Oh, I got the Stopping Pain that just came out. It might be opposite, but that one just came out of the press. And then I got Revolutionary Ketamine that I wrote with Gavin G. Becker. He's wrote The Gift of Fear. And so those have gone well. And then look up my video, that Speak Health, which is like I said, a form of TED Talk that I did on the revolutionary ketamine that went very well. And I'm pretty proud of it. I the book was, even if the book saved one life, it was all worth it. And it has.
Yes,
And honestly, it has. And that's, so I can't complain, man. That's been good
that's
to me.
great. Well, thanks for being here, John.
Thank
Hope to see you
you.
at
Thanks.
some
That's
point
so cool to, hey,
soon.
it's just like hanging out.
That's what we try to do here. But enjoy the rest of your day, and let's hopefully see each other soon, okay?
Let's see each other soon, Scott. Thanks. Say hi to Ted. All right, man. Thanks again. Bye-bye.
Thanks so much for listening to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I really hope you enjoyed this interview with Dr. Johnathan Edwards. We talked about ketamine, we talked about stellate ganglion blocks, percutaneous hydrotomy, and some great stories along the way. If you like this podcast, please don't forget to like and subscribe below. Please share with your friends and family. We'll see you next time.